Hi, Miss Leek. It's Kristen, and I'm performing my newborn assessment. I have my newborn baby doll right here. And before I begin my assessment, I'm going to take a look at the patient's charts to get an idea of the birth history, to find out if it was a vaginal or cesarean delivery, to see if there were any complications, to check if the mom's planning to bottle or breastfeed, just certain things, including previous vital signs that may have been taken and measurements as well, just to have an idea of what I'm going to find when I enter the room. When I enter the room, I'm going to want to introduce myself to the parents as a nursing student, and I'm going to let them know that I'm going to be performing a newborn assessment on their baby. I'm going to ask them if they have any questions regarding the assessment, and I'm also going to check the baby's ID bracelet and the mom's to make sure that I have the right patient. Once I'm ready to begin, if the parents don't have any questions, first I'm going to assess the baby and make sure that the newborn isn't showing any signs of distress, to make sure that it's safe for me to continue with the assessment and that the child is safe. Once I've determined all of those factors, I'm going to close the curtain for privacy and perform hand hygiene and begin. I'm going to start by taking the temperature, and I'm going to place the thermometer in the axilla lengthwise across the body to get an accurate temperature reading. And the normal temperature range is about 97 to 99 degrees Fahrenheit. And I'm going to continue by listening to the apical pulse and assessing the apical pulse rate for a full minute, placing it in the appropriate spot and listening for 1 full minute, and the typical apical pulse rate is going to be 110 to 160 beats per minute. And after that full minute has passed, I'm going to leave my stethoscope and listen for murmurs and hear if I hear any murmurs. After assessing the apical pulse, I'm going to place my hand on the baby's belly and assess the respiratory rate based on the extension of the abdomen and feeling the breaths that way. And I'm going to perform that for a full minute, and a typical respiratory rate is going to be 30 to 60 breaths per minute. And so I'm going to continue with my head circumference, measuring it across the brow line, typical head circumference being 33 to 37 centimeters, and then with a chest circumference, again taking the tape measure across the nipple line, and typical chest circumference being 30 to 33 centimeters. And I'm also going to measure the length, which should be about 44 to 55 centimeters, and weight, which the range is 5.5 to 8.5 pounds. And those are all the average ranges for those categories. And I'm going to continue on with the general appearance of the baby, noting an appropriate cry, the muscle tone, that they're able to move all the extremities, that they have all of their extremities, and they're able to move them symmetrically, noting any palsies, discoloration of the body parts, and continuing on with the skin specifically, taking a look at the milia across the cheekbones and on the face, letting the parents know not to pick at it or scratch at it or try to pop it, looking for vernix on the newborn as well as lanugo on the shoulders and ears and everywhere else. The erythema, which again is a typical finding in newborns, and also taking a look at Mongolian spots all over the baby, but particularly along the buttocks, and while looking at the baby's back, checking for the vertebral alignment, looking for any spina bifida or any openings in that vertebral column. And also taking a look for the petechiae, as well as Epstein pearls. And when assessing the Epstein pearls in the mouth, I'm going to take a gloved hand or a gloved finger and place it in the mouth and assess for the Epstein pearls. Also assessing for any baby teeth, any newborn teeth, as well as assessing the hard and soft palates for patency. And just lightly taking my finger and very lightly pressing or assessing, rubbing my finger along the top of those palates to make sure that they're patent. And also seeing if this initiates a suck and swallow reflex in the newborn, with my finger placed in their mouth. And so then moving on to the head, assessing the fontanelles. The anterior fontanelle should be larger and diamond shaped, and the posterior fontanelle assessing for bulging, doing this while the baby's not crying, assessing for the bulging or if the fontanelles are sunken in. Also taking a look at any molding or caput or cephalhematomas that have formed on the baby's head. Looking at the face, making sure it's symmetrical. Eye, nose, and mouth are all symmetrical. Looking at the grimace, if there's a grimace or any kind of facial expression on the infant during the cry. Taking a look at the eyes and noting the iris color, making sure that the pupils are equal and reactive to light. And they may not be able to accommodate yet. They probably will not be. And taking a look at any conjunctiva on the eyelid. Making sure that the outer canthus lines up with the ear, and making sure that the ear isn't lower or higher, that it's very symmetrical and lined up. And while taking a look at the ear, looking for any dimpling or dimpling or tags on the ear and around the tragus area, and making sure that the ear is well formed. And then we already assessed the mouth and patency, but we're going to take a look at nasal patency as well. So taking my pen light and shining it in and making sure that the nose is patent. Taking a look at the neck and clavicles, making sure that the clavicles are not broken, assessing for any shoulder dystocia from birth, and mainly making sure that the clavicles are still intact and not broken. And then moving down to the chest and making sure that the chest is symmetrical, that it's not a barrel shape, that it's not concave, that it's the appropriate size. Along with the nipples, making sure that they're the appropriate size and symmetrical, there's no nipple discharge. And taking a look at the breast buds underneath the nipples and palpating both of those, and checking for any kind of engorgement in the nipple area. And I'm also going to take my stethoscope and auscultate the breath sounds anterior and posteriorly, making sure to note that within 24 hours of birth, what breath sounds are a common finding. And after I've assessed breath sounds and symmetrical chest movement, we're going to move to the abdomen, asking about the voiding patterns of the child. Have they passed their meconium? Are they able to urinate appropriately? If the child is under 12 hours old, I'll be able to assess the umbilical cord for the 2 arteries and 1 vein. Also, if the baby's had their first feeding, auscultating the abdomen and listening for those bowel sounds. And then moving on to the genitals, taking off the baby's diaper. For girls, checking that the labia covers the clitoris. And for boys, checking the meatus, making sure that it's centrally located, palpating the scrotum for the testy location, and noting the rugae on the scrotum. For the extremities, again, just making sure that they're able to move the extremities bilaterally, that they have good muscle tone, good range of motion. Also checking for hip dislocation, doing the Ortolani maneuver, which is hard to do on this baby doll because it's so stiff, but pretty much for the Ortolani you want to bring the legs up to the chest and then out. So up and out, and assessing for a clicking noise that indicates a hip dislocation. And also assessing the feet and the plantar reflex and the palmar reflex, making sure that they're able to grip on. And making sure that the anus is patent. So going over and making sure that the anus is patent. And then moving on to the reflexes. We've already done the plantar and palmar reflexes. And then now going to the Moro or startle reflex, and not removing your hands but initiating that startle reflex. Tonic neck, by moving the baby's arms out and seeing if their head follows. The rooting reflex, checking that the baby's head turns after brushing. And the stepping reflex, that they raise their feet. and Babinski, going up and across the foot, watching the toes fan out, and Gallant, pushing it down the side and watching the baby turn into the stimulation. And so that completes my assessment. I'm going to ask the parents about the sleeping patterns of the infant. The first hour where they're the most